Hello, everyone. My name is David Odeej, and welcome to today's session. In this lecture, we'll be discussing cardiovascular disorders. The cardiovascular system, comprising the heart and blood vessels, is vital for maintaining homeostasis. Hypertension, a common disorder, increases the risk of coronary artery disease and stable angina. Heart failure, including pediatric cases, results from the heart's inability to pump effectively, necessitating comprehensive management strategies. We are discussing Chapter 35, Cardiovascular System of our book, Lewis's Medical Surgical Nursing, Assessment and Management of Clinical Problems. The cardiovascular system, comprising the heart, blood vessels, and blood, circulates blood to supply oxygen and nutrients while removing waste. Blood pressure regulation is vital, influenced by age, weight, genetics, diet, activity, stress, and habits like smoking. Medications can also impact blood pressure, either increasing or decreasing it. The heart consists of four chambers: right atrium, right ventricle, left atrium, and left ventricle. It also has four valves: tricuspid, bicuspid, mitral, pulmonic, and aortic. These structures ensure efficient blood flow, oxygenating the body and removing carbon dioxide. Understanding this is crucial for comprehending blood circulation dynamics. Blood enters the superior or inferior vena cava, reaching the right atrium, then moves to the right ventricle. It travels through the pulmonary artery to the lungs, returns via pulmonary veins to the left atrium, flows into the left ventricle, and is pumped through the aorta to the rest of the body. The heart's anatomy includes four chambers: right atrium, right ventricle, left atrium, and left ventricle. Key structures also involve the aorta, pulmonary arteries, and veins. Understanding these components is crucial for labeling and comprehending the heart's function in blood circulation. Would you like to label the heart? Blood flows through the heart in a specific sequence. Deoxygenated blood enters the right atrium, moves to the right ventricle, and is pumped to the lungs. Oxygenated blood returns to the left atrium, flows into the left ventricle, and is then circulated throughout the body. This efficient flow ensures oxygen delivery and waste removal. Would you like to label the path? The heart's conduction system includes the sinoatrial, SA, and atrioventricular, AV nodes. The ECG pattern shows the P wave for atrial depolarization, QRS complex for ventricular depolarization, and T wave for ventricular repolarization. The U wave may indicate Purkinje fiber repolarization or hypokalemia. PR, QRS, and QT intervals measure impulse travel time. The electrocardiogram, ECG/EKG, records the heart's electrical activity. It captures the P wave, QRS complex, and T wave, reflecting atrial depolarization, ventricular depolarization, and ventricular repolarization, respectively. The PR, QRS, and QT intervals indicate the time taken for electrical impulses to travel through the heart, crucial for diagnosing cardiac conditions. The vascular system comprises arteries, veins, and capillaries. Arteries, excluding the pulmonary artery, transport oxygenated blood from the heart, while veins, except pulmonary veins, return deoxygenated blood. Arterioles and venules are smaller branches. Capillaries, connecting arterioles and venules, facilitate nutrient and metabolic exchange. The autonomic nervous system regulates cardiovascular function. The sympathetic nervous system increases heart rate and contractility via beta adrenergic receptors, while the parasympathetic system decreases heart rate through the vagus nerve. Blood vessel tone is controlled by alpha adrenergic receptors, causing vasoconstriction or vasodilation. Baroreceptors and chemoreceptors modulate these responses based on pressure and chemical changes. Blood pressure is the force of blood against arterial walls, measured as systolic and diastolic pressures. Systolic is peak pressure during heart contraction, while diastolic is during relaxation. Normal values are systolic blood pressure less than 120 millimeters of mercury and diastolic blood pressure less than 80 millimeters of mercury. Key determinants include cardiac output and systemic vascular resistance. Measurement methods range from invasive arterial catheters to non-invasive sphygmomanometers and Doppler flow meters. Point. Hemodynamic monitoring assesses cardiovascular function by measuring pressure, flow, and oxygenation. It evaluates heart function, including cardiac output and contractility, fluid balance through preload and afterload, and response to therapies like drugs, intravenous fluids, and vasopressors. This comprehensive evaluation is crucial for effective patient management and treatment adjustments. Hemodynamic monitoring can be non-invasive or invasive. Non-invasive methods include blood pressure measurement, echocardiography, and Doppler ultrasound. Invasive techniques involve arterial lines for blood pressure and gas monitoring, central venous pressure lines, and pulmonary artery catheters, such as the Swangans, for comprehensive cardiovascular assessment. Preload refers to the blood volume in ventricles before contraction, influencing cardiac efficiency. Afterload is the resistance the heart must overcome to eject blood. Cardiac output, calculated as heart rate times stroke volume, and cardiac index, adjusted for body surface area, are crucial for assessing heart function. Systemic vascular resistance indicates vascular tone, while mixed venous oxygen saturation reflects tissue oxygen balance. Arterial lines inserted into radial or femoral arteries provide continuous blood pressure monitoring and allow for blood sampling. Central venous catheters placed in jugular or subclavian veins measure right atrial pressure. Pulmonary artery catheters inserted via central veins into the right heart assess cardiac output, pulmonary pressures, and mixed venous oxygen saturation. Nursing management begins with assessing baseline indicators like general appearance, level of consciousness, skin color, temperature, vital signs, pulses, capillary refill, and urine output. Key observations include fatigue, pallor, mental status changes, and decreased urine output, indicating reduced cardiac reserve and perfusion. Recognize shock clues. Hypovolemic shock shows initial stable blood pressure, later pallor. Septic shock presents warm skin. Tachycardia, unstable blood pressure. Integrate clinical assessments with technology for early recognition and timely intervention. Now we will discuss ECG studies used to evaluate heart rhythm and electrical activity. First, we have the 12-lead ECG, which is the most common and essential diagnostic tool. It records the heart's electrical activity from 12 different perspectives, allowing detection of arrhythmias, ischemia, and myocardial infarction. As nurses, our role is to ensure proper skin preparation, correct lid placement, and patient comfort. We must also instruct the patient to remain still and breathe normally during the test to prevent artifact interference. Next, the ECG event monitor or loop recorder is used for patients who have infrequent episodes of palpitations or dizziness. This device can be worn for weeks or even months and is activated by the patient when symptoms occur. Our nursing responsibility includes teaching the patient how to use the recorder properly, how to document symptoms, and ensuring the device remains in good working order. Next, let's review some imaging diagnostic studies used in heart disease. Chest X-ray shows the size, shape, and position of the heart, as well as lung congestion or fluid buildup. Nursing responsibility. explain the procedure, ensure removal of metal objects, and protect the patient from unnecessary radiation exposure. Cardiac CT/electron beam, CTEBCT, provides detailed images of the heart and coronary arteries. EBCT detects calcium buildup, helping to identify coronary artery disease early. Nursing responsibility, check for iodine or contrast allergy, ensure the patient is NPO if contrast is used, and encourage fluids after the scan to flush out contrast material. Coronary CT angiography, CTA, uses IV contrast and CT scanning to visualize coronary arteries and detect blockages or plaque buildup. Nursing responsibility, assess renal function before contrast use, monitor for allergic reactions, and instruct the patient to remain still during the scan for clear imaging. Now we will discuss Chapter 36, Hypertension or high blood pressure, which is a critical modifiable risk factor for cardiovascular disease. Hypertension or high blood pressure significantly elevates the risk of cardiovascular diseases like myocardial infarction, heart failure, and stroke. It also contributes to renal disease and vision loss. Understanding hypertension as a modifiable risk factor is crucial for preventing these severe health outcomes. Hypertension prevalence varies by race and gender. Blacks have the highest rates and face severe complications. Hispanics often lack treatment and awareness. Men are more affected before middle age, while women face increased risk with oral contraceptives and age. Older women find hypertension harder to control despite treatment. Hypertension is categorized into primary and secondary types. Primary hypertension, accounting for 90 to 95% of cases, lacks an identifiable cause but is influenced by factors like high sodium intake, obesity, and lifestyle. Secondary hypertension, comprising 5 to 10% of cases, has identifiable causes such as obstructive sleep apnea and renal disease. Hypertension often remains asymptomatic until it reaches a severe stage. This silent progression can lead to serious complications, including heart disease, stroke, kidney damage, and vision loss. Understanding these potential outcomes is crucial for effective management and prevention strategies. Common complications include 1. Cardiovascular system coronary artery disease, CAD, left ventricular hypertrophy, LVH, heart failure. 2. Cerebrovascular system stroke, CVA, transient ischemic attack, TIA. 3. Peripheral vascular system, peripheral arterial disease, PAD. 4. Renal system chronic kidney disease, CKD, renal failure. 5. Retinal damage, hypertensive retinopathy, blurred vision or blindness. Diagnostic studies for hypertension include history and physical assessment, ophthalmic examination, and fasting blood glucose. Routine urinalysis, basic metabolic panel, and complete blood count are crucial. Creatinine clearance, serum lipid profile, and 12-lead electrocardiogram help evaluate cardiovascular risk and target organ disease, while blood pressure measurement is essential for monitoring. Interprofessional care involves collaboration among healthcare professionals to optimize patient outcomes. This approach ensures comprehensive management of hypertension by integrating expertise from various disciplines, such as nursing, pharmacy, and dietetics. Now let's talk about Life's Essential 8, an approach by the American Heart Association that focuses on improving cardiovascular health through a team-based interprofessional model of care. The first is maintaining a healthy diet, emphasizing fresh whole foods and reducing salt and fat intake. Next is regular physical activity, at least 150 minutes of moderate exercise per week. Avoiding nicotine exposure, both active smoking and secondhand smoke, is critical for heart protection. Good sleep hygiene, about 7 to 9 hours a night, also supports cardiovascular function. We then focus on maintaining a healthy weight, as obesity is a major risk factor for heart disease. Managing cholesterol and blood glucose levels through diet, exercise, and medication helps prevent atherosclerosis and diabetes-related heart damage. Finally, controlling blood pressure through regular monitoring and treatment adherence is essential in preventing complications like heart failure and stroke. Drug therapy involves various classes of medications, each with specific monitoring needs. Diuretics require electrolyte and renal function checks. Beta blockers necessitate heart rate and blood pressure monitoring. ACE inhibitors and angiotensin receptor blockers need potassium and renal function assessment. Calcium channel blockers require blood pressure and heart rate monitoring, while alpha blockers and vasodilators demand careful blood pressure observation. Diuretics require monitoring of electrolytes and renal function, with attention to hypokalemia or hyperkalemia. Beta blockers necessitate heart rate and blood pressure checks, especially in asthma patients. ACE inhibitors and angiotensin receptor blockers need monitoring for hyperkalemia and renal function. Calcium channel blockers require blood pressure and heart rate monitoring, avoiding grapefruit juice. Alpha blockers and central acting alpha 2 agonists need careful blood pressure monitoring to prevent orthostatic hypotension and rebound hypertension. Here's the classification of antihypertensive drugs used to treat hypertension. Everyone must remember it by simply remembering AAABCD, meaning assessing hypertension involves gathering subjective data like health history, medication use, lifestyle, and nutrition. Objective data includes cardiovascular and neurological signs, while diagnostic findings focus on lab results and cardiac assessments. Understanding these elements is crucial for effective management and treatment planning. Educate clients and caregivers on managing hypertension. Explain blood pressure readings and self-monitoring techniques. Highlight the importance of therapy for control, as controlled hypertension leads to an excellent prognosis. Discuss specific medications, their actions, and potential side effects like orthostatic hypotension and sexual issues. Advise against prolonged standing, and note that some drugs may lose effectiveness over time. Orthostatic hypotension occurs when a person's blood pressure drops suddenly upon standing, leading to dizziness or even fainting. This happens because blood pools in the lower body and the brain gets less oxygen for a few moments. To prevent this, patients should rise slowly, stay well hydrated, and wear compression stockings. If symptoms occur, the best action is to sit or lie down immediately, raise the legs, and rest until feeling better. Persistent symptoms should always be reported to the healthcare provider. Now we will discuss Chapter 37, Coronary Artery Disease, of our book Lewis's Medical Surgical Nursing, Assessment and Management of Clinical Problems. Coronary artery disease, CAD, is a blood vessel disorder under atherosclerosis, where fatty deposits harden in arteries. When these deposits form in coronary arteries, it leads to CAD, also known as arteriosclerotic heart disease, cardiovascular heart disease, ischemic heart disease, or coronary heart disease. The term atherosclerosis combines athero, meaning fatty mush, and sclerosis, meaning hardening. Risk factors for coronary artery disease include non-modifiable elements like age, ethnicity, gender, and genetics. Modifiable factors encompass high blood pressure, diabetes, elevated lipids, obesity, inactivity, tobacco use, metabolic syndrome, and type A personality. Cultural and gender considerations reveal disparities in incidence and mortality, with white males having the highest rates and women experiencing heart disease onset later than men. Managing coronary artery disease involves regular physical activity and nutrition therapy. Engage in rhythmic exercises like walking or swimming most days, starting with 5 to 10 minutes and aiming for 30 minutes. Reduce saturated fats, increase complex carbs, and consume healthy fats like nuts and olive oil. Limit alcohol and simple sugars, and include omega-3 rich fish twice weekly. Lipid-lowering drug therapy is crucial in managing coronary artery disease. Statins are the first-line treatment, significantly reducing low-density lipoprotein cholesterol and cardiovascular events. Ezetimibe complements statins by inhibiting cholesterol absorption. Proprotein convertase, subtilisin, kexin, type 9 inhibitors offer potent low-density lipoprotein reduction for high-risk patients. Bile acid sequestrants and fibrates target low-density lipoprotein and triglycerides, respectively, while niacin increases high-density lipoprotein but has limited use due to side effects. Antiplatelet therapy, particularly low-dose aspirin 81 milligrams, has been a cornerstone in coronary artery disease prevention. While beneficial for adults aged 40 to 59 with high coronary artery disease risk and low bleeding risk, its primary prevention use is controversial due to bleeding risks. For adults age 60 and above, starting aspirin for primary prevention is not recommended. Coated aspirin is preferred to minimize gastrointestinal irritation. Coronary artery syndromes include stable angina, unstable angina in a STEMI, and STEMI, which differ mainly in severity of blockage, ECG changes, and cardiac enzyme elevation. Stable angina ECG may show transient ST depression or T wave inversion, and troponins remain normal. Unstable angina ECG may also show ST depression or T wave inversion, but troponins are not elevated. In NSTEMI, ECG shows ST depression or T wave inversion, and troponins are elevated. STEMI ECG shows ST segment elevation, and troponins are markedly elevated. Chronic stable angina is characterized by intermittent chest pain with a consistent pattern. It often radiates to the jaw, neck, shoulders, or arms, and may feel like indigestion. Typically lasting a few minutes, it subsides when the trigger is resolved. It's primarily caused by increased oxygen demand or decreased supply due to narrowed coronary arteries from atherosclerosis. Angina can be categorized into stable, unstable, Prinzmetal's, and microvascular types. Stable angina is predictable and occurs with exertion. Unstable angina is unpredictable and may occur at rest, indicating a higher risk of heart attack. Prinzmetal's angina involves coronary artery spasms, while microvascular angina affects the heart's smallest arteries, often with normal coronary arteries. Assessing angina involves understanding precipitating events like exercise or rest and the quality of pain, such as pressure or tightness. Identify the pain's location and radiation to areas like the neck or arms. Evaluate severity on a 0 to 10 scale and consider timing, including onset and changes over time. Stable angina occurs predictably with exertion or emotional stress and is relieved by rest or nitroglycerin. It results from a fixed atherosclerotic plaque that limits blood flow during increased oxygen demand. In contrast, unstable angina is unpredictable, often occurring at rest or with minimal exertion, and is not fully relieved by nitroglycerin. It usually results from plaque rupture and partial thrombus formation, leading to reduced coronary perfusion even at rest. Unstable angina is considered a medical emergency because it can progress to a myocardial infarction if untreated. Preventing angina focuses on reducing the heart's workload and improving blood flow to the heart muscle. Patients are advised to adopt a heart-healthy lifestyle. This includes quitting smoking, eating a balanced diet low in saturated fats and sodium, maintaining a healthy weight, and exercising regularly as recommended by the healthcare provider. Effective angina treatment involves a multifaceted approach: antiplatelet and anticoagulant therapies, anti-anginal medications, and ACE inhibitors or angiotensin receptor blockers. Beta blockers and blood pressure control are crucial. Lifestyle modifications include smoking cessation, cholesterol management, and cardiac rehabilitation. Addressing diet, diabetes, and depression is essential, alongside education, exercise, and flu vaccination. Nitrates, such as sublingual tablets and transdermal patches, help dilate blood vessels. Nitrates are crucial in angina management, working by dilating blood vessels to improve blood flow. Options include sublingual tablets, translingual spray, oral nitrates, nitro paste, and transdermal patches. Each form offers unique benefits tailored to patient needs, ensuring effective symptom relief and improved quality of life. Coronary artery stenting involves placing a stent at the lesion site. A balloon is inflated to expand the stent, which is then left in place after the balloon is deflated and removed. This procedure helps maintain artery patency, crucial for preventing myocardial infarction and improving blood flow. Non-ST elevation myocardial infarction involves a non-occlusive thrombus, showing no ST elevation on electrocardiogram, possibly ST depression or T-wave inversion. Managed with catheterization within 12 to 72 hours without thrombolytics. ST elevation myocardial infarction features an occlusive thrombus with ST elevation on electrocardiogram, requiring artery opening within 90 minutes via percutaneous coronary intervention or thrombolytics if percutaneous coronary intervention is unavailable. Delayed treatment risks pathologic Q waves and permanent damage. In acute coronary syndrome, nursing management focuses on immediate priorities using MONA-B, morphine for pain, oxygen if peripheral capillary oxygen saturation is less than 90%, nitroglycerin for vasodilation, aspirin to prevent thrombus, and beta blockers to reduce oxygen demand. Continuous electrocardiogram monitoring, vital signs assessment, and patient education on medication adherence and lifestyle changes are crucial for ongoing care. Sudden cardiac death occurs abruptly, often within an hour of symptom onset, primarily due to cardiac causes. Clinical signs may include angina, palpitations, and dizziness. Diagnostics involve cardiac biomarkers, electrocardiogram, and catheterization. Prevention focuses on implantable cardioverter defibrillators, antiarrhythmics, and wearable defibrillators. Rapid cardiopulmonary resuscitation and early defibrillation are crucial for survival, alongside emotional support and education on device use and lifestyle changes. Thank you so much for watching and staying with us. Your attention truly means a lot. Don't forget to check out the next part of our series on heart failure. It's packed with important information you won't want to miss.